We'll get going. All right. Thank you all for joining us today, and welcome to a new academic year of What's New in Addiction Medicine lectures. Although our speaker today is off cycle, so he's been with us. This is not his first lecture to attend, at least. Again, Paxton Bach, the fellowship director, very happy to introduce Alex today, and I'll help facilitate some Q&A once he's done. So welcome to Alex Wong, one of our current addiction medicine fellows. Alex is a family physician and a public health resident, along with his role as a BCCSU addiction medicine fellow. He has an interest, not surprisingly, in the intersection of substance use, social determinants, and health policy. And Alex completed his med school at the U of A, as well as family medicine residency at the U of C, before coming to join us. He was recently practicing primary care at the Three Bridges Community Health Center, while also completing his master's in public health at UBC, until coming back to us to finish his addiction fellowship. In his future career, Alex hopes to practice a combination of clinical addictions care and public health, and he's here today to speak to us about a question that we probably don't spend enough time talking about, in the urgency that we all feel on initiating treatment for an opioid use disorder with opioid agonist therapy. There comes a second question that may come early in treatment or may come a bit later about if, when, and how to taper these medications. So Alex is going to talk to us about the evidence and some clinical pearls around navigating patient requests to taper opioid agonist therapy. Take it away, Alex.
Thanks for the introduction, Paxton, and thanks so much, everyone, for attending my talk today. My presentation is titled Navigating Patient Requests to Taper Opioid Agonist Treatment. And I chose this topic because it's a common clinical scenario I've encountered both in family medicine practice and during the course of my BCCSU fellowship so far. And it's one that I found sometimes personally challenging. Like, Paxton mentioned, like we often feel, in the context of this public health crisis, an urgent need to put people on OAT. And we know how beneficial it is. So by doing this as my What's New in Addiction Medicine talk, I hope to shed some light on what existing evidence tells us about OAT tapering and some considerations to keep in mind when patients come to us with this request. And so just before I begin, I'd like to respectfully acknowledge that I'm a settler on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I acknowledge that the current ongoing toxic drug crisis has had a disproportionate impact on Indigenous communities, and that more work needs to be done to address the social determinants that have led to health inequities for Indigenous peoples. I have no conflicts of interest to declare. This is just a review of the objectives for today. So first, I want to review some literature surrounding tapering OAT, including reasons why patients might request a taper. We'll discuss an approach to counseling patients considering tapering OAT, taking into consideration the concept of recovery capital. And then I'll close off with discussing clinical approaches to tapering OAT. The outline for today, I'll just start with a brief overview of OAT and OAT tapers. I'd like to delve into some patient perspectives on OAT tapers and some of the qualitative research that's been done on this topic. I'll then talk about specific considerations for counseling patients requesting OAT tapers. We'll talk about who ideal candidates for OAT tapers are, and the concept of recovery capital. And then we'll talk about clinical strategies for tapering OAT, and then future directions for research and current gaps in the literature. So I think everyone here in attendance here is familiar with what opioid agonist treatment, or OAT, is, so I won't go into too much detail. The important thing to know, our OAT medications are the mainstay in terms of our pharmacologic options to treat people with opioid use disorders. So it includes methadone, buprenorphine, or Suboxone, slow-release oral morphine, or Cadian. We have the extended-release buprenorphine, which is the once-a-month injection Sublocade, and also include fentanyl patches in this category as well. And so with the ongoing public health crisis due to toxic drug deaths, we know that OAT are life-saving medications. They have clear and strong evidence base to support their use to reduce mortality and morbidity from substance use. And you can see this on the graph on the slide. I took it from a retrospective cohort study that was done here in BC. It compared the mortality rate of individuals with OUD who are on OAT. So that's the purple line versus individuals who are not on OAT. So that's the yellow line. And so you can see the mortality rate of the purple line is significantly lower. So it's approximately 3.5 times lower on average compared to the yellow line. And even with the introduction of fentanyl into BC's drug supply, which occurred around 2016 when the public health emergency was first declared, we don't see a corresponding increase in mortality among people on OAT, even though there's a steep increase in the yellow line. And so besides mortality benefit, we also know that OAT has other benefits in terms of increasing retention in treatment programs. It reduces the risk of transmission of bloodborne infections like HIV, hepatitis. It improves quality of life and gives people with OUD stability by providing long-acting opioid to manage their craving and withdrawal symptoms. And we also know that the evidence shows that there's a strong association between discontinuing OAT medications and high rates of relapse and overdose. And this is particularly high in the immediate period after stopping OAT. So this is shown in the two graphs on the slide. It was also taken from the retrospective cohort study I just mentioned. The yellow squares represent mortality rates for people on methadone, and then the purple dots are mortality rates for patients on Suboxone. And as you can clearly see, the mortality when off OAT, so that's on the right graph, they're substantially higher compared to when they are on OAT, which is on the left graph. And this is especially high in the first 4 to 12 weeks after stopping OAT. And so because of this, most guidelines, including the 2023 BCCSU opioid use disorder guidelines, it recommends OAT to be considered as an open-ended treatment that should be taken by patients indefinitely in the long term, with the rationale being that we know substance use disorders are chronic relapsing conditions. And I know some people find framing addiction as a chronic disease like diabetes can be helpful in helping patients and their families understand this. So just like a patient with diabetes usually requires blood sugaring, lowering agents for life, patients with OUD also require OAT for life. And if you actually look into the evidence-based, we really don't have any clear literature to guide us about how long someone should be on OAT for. If you look at the BCCSU guidelines, they have a recommendation, like we discussed, that OAT be viewed as an open-ended treatment, so with no end date. However, it does state that if a patient wishes to discontinue and taper their OAT, it should be following a sustained period of at least 12 months of stability or more. So this 12-month benchmark is also endorsed by guidelines from CAMH in Toronto, as well as ASAM, which is the American Society of Addiction Medicine. It mostly represents expert opinion, though, along with some observational studies that show that longer treatment duration increases the likelihood of successful discontinuation. But there's some subjectivity in determining what clinical stability is. So it can incorporate a bunch of different criteria that's not clearly defined. Does it mean the patient has to be completely abstinent from unregulated use, or could a patient who still uses small amounts also be considered stable? Does stable mean they have no missed OAT doses, or they have no recent overdoses, or does it mean that they're attending their medical appointments, or that they have stable housing with income support? Likely, the answer is clinical stability probably incorporates some element of all of these things. But my point is that the current literature really is not totally clear in defining optimal OAT duration or criteria to look for considering discontinuation or taper. I think the challenging part of OAT tapers is we know that there's overwhelming evidence in support of OAT. But requests to taper OAT are still a very commonly encountered clinical scenario. And different studies using surveys estimate that between 60 to 90% of patients have interest in eventually coming off or discontinuing OAT. And I think as clinicians, patient requests for tapering often makes us feel uncomfortable and nervous because we know the risks of not being on OAT. And tapering OAT is basically a long-term withdrawal management strategy, which the BCCSU guidelines and most international guidelines don't support because of the high risk of relapse and overdose, especially with how toxic the current drug supply is. So I think, my gut instinct I kind of feel uncomfortable when patients ask this, try to say no, dissuade them from doing it because, we don't want to be responsible for someone potentially, overdosing or dying if they stop their OAT medication. But the reality, I think, is that patients will often try to taper or discontinue it themselves, whether we're on board or not. And I think trying to bridge this gap between what the patient wants and what we as clinicians want, we should try to put ourselves in the patient's shoes and try to understand why they're seeking to stop their OAT in the first place. And, as medical professionals, I think, we're most comfortable and familiar with quantitative research, like, randomized control trials, cohort and case control studies. They give us a nice, summary measure of association, like relative risk or odds ratio. But in this case, to understand the fundamental reasons why people want to discontinue OAT, I think, we need to lean on qualitative methods to understand, some of the human and psychological factors involved in this. So one of the most common reasons people want to discontinue an OAT is it's very inconvenient. I mean, daily witness dosing at the pharmacy, that's why sometimes people will call methadone liquid handcuffs. It places restrictions on someone's life that can make work, school, just living in general kind of difficult. And while carry doses can be given, the bar to reach carry doses is quite high because we know the potential risk of OAT medications if they're taken by someone else or if they're diverted. So, many guidelines, including the ones in BC, recommend that carry doses should only be considered when we have concordant urine drug screening results for a sustained period of time, usually at least 3 months, for stable patients who can safely store their medications. And it's a criteria that many patients are not going to be feasibly met, especially by our population here working in the downtown east side. Another common concern from patients are about side effects of OAT. So they can include sedation, fatigue, cardiac arrhythmias from prolonged QTC, from methadone, erectile dysfunction, and hypogonadism. And I often hear, patients will say that the methadone is rotting their teeth and their bones. And patients may also feel pressure to be off medications, and it comes from external sources like family members, friends, workplaces, or an internal source within themselves. And usually it's rooted, from stigmatization of substance use disorders and being on OAT medications. And unfortunately, we also have, some treatment programs, unfortunately, require patients to not be on certain OAT medications in order to be eligible to be accepted into them. And there's also the piece about financial or travel restrictions. Here in BC, not as much of a problem because OAT medications are covered under pharmacare, but financial costs of paying for OAT or transportation to and from pharmacy can be a barrier in patients continuing on OAT. And there may also be restrictions on, traveling out of town. Like if a patient wants to go somewhere, they usually have to find a pharmacy at a location they're traveling to that can provide their OAT medications while they're away from home. So delving into some of the qualitative studies on this topic, I want to highlight this ethnography that was done in 2016. It was done in Norway, and one of the researchers spent a lot of time with individuals with opioid use disorder who are enrolled in a methadone or Suboxone treatment program. And while there were many positive experiences about being on OAT, there are other themes that emerged too. And one of which was this feeling of being trapped or stuck in limbo. And patients would describe their fear of going into withdrawal if they stop taking their medications. And then there's also fear that their urine drug screens might be used against them punitively, like to take away their medications or carry doses if it was discovered that they were still accessing unregulated supply. And another theme was around stigmatization of their identity. So many people describe feeling, excluded or alienated from like quote unquote like ordinary society if people were to find out that they were on OAT. And so one participant was quoted as saying, when my family and friends found out about my drug use and the methadone program, rumor quickly spread in the neighborhood. The neighbors and the other mothers at the nursery stayed away from me. My adult siblings stopped giving me lifts and no one would lend me money. So I think that, just speaks to the stigmatization if, people were to find out someone was on OAT medications. And another aspect is that they lose a sense of identity and community they have developed that was related to using substances. And so one participant was quoted as saying, when I joined the methadone program, I felt as though the things about me that were appreciated in the drug community lost their value and I became no one. And I think we forget that sometimes I think while starting OAT, of course, is a good thing, there can be feelings of being lost or of grief about losing a way of life or a community that you've gotten used to. And last theme that was noted by the researchers was a loss of hope. And many participants would describe feeling very optimistic prior to starting methadone or buprenorphine that it would, quote, straighten out their lives. But when this does not necessarily happen, many people feel disillusioned about, their recovery journey. And I think this reflects what we all know, even though medications are a important and crucial aspect of treating addiction, it's not sufficient by itself and requires to address psychological factors and social determinants of health as well. And when I found the study, I was actually a bit surprised. I think that so many of the themes were negative, given how beneficial we know OAT is. I think just being open-minded and holding space for complexity is important in this topic, and more than one thing can be true at once. We know that methadone and Suboxone are life-saving medications, but can also be true that sometimes these medications make people feel trapped or tied to an old version of themselves that they want to move on from. Another Paula study, I think, shed lights on this topic. It was done here in BC on street entrenched youth with OUD living in Vancouver. So these are youth that are enrolled in the longitudinal at-risk youth study cohort. And the researchers were aiming to figure out how youth view themselves and the trajectory of their opioid use disorder. And I would definitely recommend reading this article. It's very insightful. But they found that youth envision and dream of a normal future that does not involve taking OAT indefinitely, with daily witness dosing and regular urine drug screening being, obstacles that they don't want to do or to continue to have to do. They also expressed concern that OAT would impair their ability to fully recover from drug use, as well as fears about side effects of taking OAT medications in the long term. And the researchers note that while it's pretty widely accepted in the medical community now to refer to substance use disorders as chronic relapsing disease, this framing may not resonate with youth. They tend to see their substance use as more of a transient behavior rather than a lifelong illness. And while I think it was empowering in a way for us to frame addiction as a disease, shift blame away from an individual to emphasize that that they need medical treatment. This framing can also be discouraging to youth, as it labels substance use disorders as something that they can never get better or recover from. So again, I think that just speaks to the complexity that's in this topic. So those two qualitative studies, I think, do a good job of illustrating some of the perceptions people have about OAT and why they want to stop taking it eventually. But of course, every individual will have their own personal reasons why they want to stop their OAT. And I think figuring out this reason should be the first step anytime a patient requests to taper their medications. So by clarifying why they want to stop their OAT, we might be able to do something to address concerns they might have. A common reason I've heard from patients is they don't want to be dependent on opioids anymore, and they view OAT as trading one addiction for another. I think in these instances, it's important to challenge the viewpoint that successful treatment requires being off OAT and trying to, address the stigma around being on medication. And when patients tell me OAT is trading one addiction for another, I try to provide some education around the difference between physical dependence and substance use disorders, which we know are a lot more than, tolerance and withdrawal. While someone might be physically dependent on their methadone or the Acadian, like they'll get sick if they miss a dose, being on OAT has likely improved other areas of their life and reduced the negative consequences of their substance use, so which is by definition treating their substance use disorder. If the concern is about side effects, we can try to provide counseling and manage these too. So if someone reports a lot of sedation or drowsiness, maybe try to reassess the dose if it's too high, and try reducing their OAT to the lowest effective dose that still manages their craving and withdrawal symptoms, as well as review their medications for other potential sedating agents, which by experience many of our patients are on, like antipsychotics. And I think, in terms of like stopping medications for side effects, we probably want to stop those other things as opposed to something that we know has very clear mortality benefit. And I see this with like QTC prolongation too, where, we often jump to stop the methadone instead of, looking at their other medications that might be contributing that, aren't as life-saving. If the worries about dental caries, I think providing education about dental hygiene, trying to send them to a dental clinic, so knowing ones in your local area that might accept lower income patients might come in handy here. And a common misconception is that the sugary juice methadone is mixed in is what causes dental cavities. And while it plays some role, xerostomia or dry mouth, it's actually class-effective opioids. It's not specific to OAT medications in particular. So continuing or relapsing to fentanyl use would also have this effect. You can suggest switching to Suboxone, which is a partial agonist, so may have less impact on dentition, but the benefit is not well studied or reported in the literature. And the same approach can be concerned about, lowered bone density factors in osteoporosis. So emphasizing preventive measures like calcium and vitamin D intake, importance of weight-bearing exercise. If they find sweats bothersome, we can offer antiperspirants or oxybutylin. For erectile dysfunction, you can offer testosterone testing and treatment as appropriate. Another commonly cited reasons, what we talked about, is the inconvenience of having daily witness dosing. So you can try to address this by reducing the barriers by using a pharmacy that does medication delivery, for example, or switch to a more flexible OAT option like Suboxone or Sublocade that don't require as frequent witness dosing or doctor appointments. You can also discuss with the patient the criteria for giving carry doses and offer them if it's appropriate. If the pressure to stop taking OAT is from an external source, like a close family member or friend, you would offer to the patient to have them bring in the concerned member to their next appointment so you can speak to them, try to address their concerns, provide some teaching there. If the pressure is from an employer, you can try to contact this employer, provide a medical letter of support, documenting that the patient should continue their OAT. If the pressure is from a treatment program, I would try to get them to consider a different program that does support patients to remain on evidence-based medications. Realistically, though, I think it's important for us to recognize that regardless of all the solutions or counseling we offer or provide, there will always be some patients who don't want to remain on OAT in the long term, no matter how hard we try to convince them otherwise. And while we can try to tell them about odds ratios and relative risks, often desire to taper OAT, I think, comes from a very human reason to want to be free or to have a sense of control over their life. In cases where patients are adamant that they want to proceed with a taper, we should try our best to provide them, just like with any other decision, all the information to make an informed choice, including about the high number of risks associated with withdrawal management, and that most OAT tapers are not successful because of relapse. So risks of OAT tapering would include destabilizing their substance use disorder, which could lead to higher risk substance use, that increases risk of overdose, infectious disease transmission, and death. And they should understand it is not something medically recommended and that it is a high risk decision. And just like in any other appointment, we should also be incorporating harm reduction and referrals to psychosocial interventions in our treatment plans. Given the high risk of overdose when tapering or stopping OAT, it's important, to give them take-home naloxone, advise them to use supervised consumption sites, and to never use alone. And if they decide to proceed with stopping OAT, advise them that long-term tapers, so over months to years, are more likely to be successful than abrupt or sudden discontinuation. And we'll talk more about the evidence to support this recommendation later. So now I should go back to the concept of stability that we talked about earlier. And so ideally, prior to considering an OAT taper, the patient should be in sustained remission, which is defined as greater than 12 months from their last unregulated opioid use, along with biopsychosocial stability. So this means that they should have been on OAT for at least 1 year minimum. And while the literature on this is not consistent, there is some evidence that suggests that the longer someone is on OAT treatment for, the greater the likelihood that their eventual tapering and discontinuation will be successful and that they will not relapse. Other criteria you might want to think about before considering tapering OAT for someone is whether the individual still has any high-risk substance use patterns. So if they're frequently coming into the ED with overdoses, for substance use related reasons, for example, that might not be the best time to taper the OAT. And if their medical and mental health conditions are unstable, you might also want to defer this. You would also want the patient to demonstrate a clear understanding and self-awareness of their own triggers of substance use, and ensure that they have the skills to formulate a relapse prevention plan, and that may involve support from community or their care team. And lastly, in my opinion, probably the most important predictor, I think, of long-term success is psychosocial stability. So really thinking about the social determinants, and if the patient has stable housing, income, food security. We know these factors are crucial, not just in recovery from addiction, but for overall health and wellness as a whole. And so, yeah, I want to focus a bit more on this piece of psychosocial stability. And I think sometimes we well intentionally, over medicalize addiction and substance use. And while abstinence is an important goal, we should support patients, of course, to strive towards. Changing their substance use behavior should not be our only focus. They also need to have function in their other areas of life, whether that be work, school, relationships, hobbies, volunteering. And really, I think the other major benefit of OAT, besides the obvious mortality and morbidity benefit, is it also gives space and stability for patients to focus on other areas of their life. So like reconnecting with family, going back to school or work, seeking mental health care, getting on housing or income support. And I think this gets at the concept of recovery, which we know is about a lot more than just medication. And in a narrative synthesis that I found, the authors reviewed existing literature and they identified 5 key things that facilitate recovery. So the first is a connection with community. 2 is optimism and hope for the future. 3 is building a positive self-identity. 4 is having a sense of purpose and meaning. And 5 is having empowerment and control over your life. And I think this part gets overlooked in our clinical work because often we focus on the immediate task of treating someone's withdrawal or titrating up their OAT. But I think it behooves us as addiction medicine clinicians to try to help people find and create purpose and belonging that's separate from their substance use. And I think it's a tall task to ask of anyone, but and ultimately, of course, it's up to the patient to figure out what's personally meaningful to them. But I think there are ways that we can better try to incorporate this in our day-to-day work better. Obviously, our clinical time is limited, but one thing I'm trying to do myself with goal setting with the patients, to ask them to set one substance use related goal. So whether that's using less or using more safely, and one other life goal. So it could be anything like calling a sibling they haven't spoken to for a while, booking an appointment with their counselor, like going to a new hobby, a class for a new hobby or something, and then documenting this in my clinical notes to follow up on our next appointment. So I think this helps build motivation and accountability in supporting patients to achieve their goals. And so this brings me to the concept of recovery capital. So it was originally a term coined by 2 researchers, Granfield and Cloud, and they describe recovery not as an end goal to be reached, but a process of lived experiences that support someone to achieve stabilization of their substance use disorder. So there was a recent review by Blanzes and colleagues. It was published in 2021, and they expanded on this idea of recovery capital by developing checklists that can be completed by patients and prescriber to try to ascertain whether a patient is ready to begin OAT tapering. And these checklists were developed based on factors noted in previous research that have been shown to be associated with readiness for tapering methadone and or Suboxone. And so I'll show some excerpts from the checklists on the next slide. But I did want to note that the authors don't intend the checklist to be used to calculate a prediction, percentage of whether someone will have a successful taper or not, but instead as a tool to assess if a patient is ready to undertake a high-risk venture. And some items of the checklist, I do know that they use more stigmatizing language. And so if you do use this article, don't feel like you have to use every item from the checklist. I think the value from it, though, is overall framework of thinking about recovery as capital that can be built and accumulated. And what I like about the checklist is that while they contain factors related to patients' physical and mental health, also includes broader areas like social connection, spirituality, hobbies, which we know can be just as important in the recovery process. So these are 2 excerpts from the checklist, the patient ones on the left, the physician one on the right, not meant to be exhaustive, but just to identify potential barriers to OAT tapering and risk factors they have for return to high-risk use. So some examples from the left-hand patient checklist are things like, are you living in a stable household or family? Do you have friends or family that can support you? Does your counselor think you are ready to taper? Do you think you would ask for help if you're feeling unwell during the taper? And the more yes answers, the better. From the physician checklist, there are items such as, are there recent requests for early refills? Or is there concurrent benzodiazepine or stimulant prescriptions? And on this list, yes answers point to potential considerations that the prescriber might want to think a bit more carefully about or about addressing prior to initiating an OAT taper. So this brings us to the last part of my presentation, which is focusing on the more practical clinical approaches to tapering OAT. And so like I said before, while we know that the overall success rate of OAT tapers are low, generally the longer the duration of the taper, the higher the likelihood of success. So this was shown in a retrospective cohort study done here in BC. It was between the period of 1996 to 2006, so this is pre-fentanyl era, but it reported an OR of 6.65 with a 95% confidence interval of 5.13 to 8.7 when comparing the likelihood of success for methadone tapers lasting greater than 52 weeks with tapers less than 12 weeks in duration. So this means that tapers more than 52 weeks in duration had 6.65 times the odds of success compared to a taper less than 12 weeks. And the authors define a successful taper in the study as a daily dose of less than 5 milligrams of methadone daily in the final week of treatment and no subsequent methadone restart. And their overall rate of success for taper times was approximately 13% in the study, so quite low. And the conclusion of the study is that while most methadone tapers are not successful, success can be enhanced by gradual dose reductions that are done in a staggered manner with periods of stabilization in between. So in other words, the dose shouldn't be decreased at every visit. You should allow some time after every dose decrease for the patient to adjust and then reassess their stability at that dose before further dose reductions. So this slide just contains some key principles from current evidence and guidelines about tapering OAT. The first we talked about earlier is engaging the patient in relapse prevention planning, including a contingency plan in case they do have increased cravings or end up relapsing. You should also frequent reassessment where you check in with the patient about their substance use patterns, any cravings or withdrawal symptoms that might emerge. So particularly might want to watch for like anxiety, headache, dysphoria, low mood, insomnia, muscle aches, irritability, impaired concentration. And we should try to create a safe environments where patients feel safe to disclose any relapses they may have and should emphasize that relapses are not failures. I'd also offer the patient the option of doing regular drug screening to aid in clinical decision-making and provide accountability if the patient themselves thinks that it would be helpful. Yeah, as discussed on the last slide, slower tapers are more success. So try to create the expectation early on that the taper will be done over months to years. Dose reduction should be done in small increments. So, I'm going to go more than like 5 to 10 milligrams. You could consider percentage-based increments so that the amount decreased is slowed as the taper progresses, as patients will be more likely to feel withdrawal symptoms at the lower doses. The dose reductions, again, should not be done at every visit and can and should be paused if craving or withdrawal symptoms emerge. And you should try to intersperse appointments where the dose is kept the same to allow the patient time to stabilize. Lastly, pharmacologic adjuncts may have a role in treating withdrawal symptoms. And the evidence shows mirtazapine, topiramate, and possibly bupropion. The evidence for this, though, came from a retrospective study looking at opioid tapering in patients with prescription OUD and chronic pain. So it may not be widely generalizable to all patients with OUD. And the thought is that these medications might be able to address certain symptoms like low mood or disturbed sleep that might come up in the tapering process. And there may also be a special role for extended release buprenorphine or Sublocade for OAT tapering. The evidence for this is not strong, but I did find a published case series of 3 successful Suboxone discontinuations after the patients were given a single injection of Sublocade 100 milligrams. All 3 of the patients in this case series had difficulty with tapering Suboxone, particularly with getting to doses below 2 milligrams due to the intensity of withdrawal symptoms they were having. But I should know that only 1 patient actually met criteria for OUD. The others were using Suboxone for chronic pain. But the idea behind using Sublocade is that given its long half-life, which anywhere from 43 to 60 days, it provides a steady serum level that auto-tapers slowly enough to avoid precipitating severe withdrawal symptoms. So more research is needed to further determine the effectiveness of this off-label use of Sublocade for this reason. And so what about after a patient completes their OAT taper? The BC CSU guidelines recommend that for patients who choose to discontinue OAT, a relapse prevention plan, should be collaboratively developed and implemented after discussion of both pharmacologic and non-pharmacologic options. So even after a patient has successfully tapered off their OAT, continue to encourage them to engage with psychosocial support, such as counseling or groups like AA or SMART. Harm reduction counseling should be continued provided given the high risk of overdose with relapse, given that they're no longer tolerant to opioids if they've not been using and they're not on OAT. Frequent follow-up and check-ins are also important, particularly in the first year when risk of relapse is highest. And you can offer pharmacologic strategies for relapse prevention as well. So that includes like oral naltrexone, which is an opioid antagonist, though evidence for this is not good, or pill-in-pocket Suboxone. It's basically when you give the patient a supply of a few tabs of low-dose Suboxone so that they can take as needed if they have cravings or the desire to use. And this can facilitate Suboxone reinduction if needed. Note that there is an extended release naltrexone formulation, though it's not currently available in Canada, but that might be another option in the future for withdrawal management. In terms of future directions, there was a recently submitted protocol for a proposed retrospective study that's going to be done here in BC with the goal to determine the ideal treatment duration someone should be on OAT for before initiating a taper. So that, for example, should a taper be initiated after 12 to 24 months of stability or after 24 to 48 months? And the outcomes they're going to be comparing are proportion of successful tapers and all-cause mortality. And I think given how common the desire to taper OAT is, more research is needed to elucidate strategies on how to do so while minimizing the risk of relapse. So other areas for future research might look into whether there's specific tapering recommendations depending on the specific type of OAT medication, like for methadone versus Suboxone versus Cadian, better tools to prognosticate who will complete OAT taper successfully, as well as tapering recommendations for a patient with comorbid conditions such as chronic pain. So these are my take-home points for today. So we know OAT is a life-saving intervention that should be encouraged to continue to be taken as long as possible. And I'm not encouraging, through this talk that we should be discontinuing OAT. But the reality is that while OAT tapering is not something that's medically recommended, it is a common patient request for a multitude of reasons, ranging from worries about side effects, and I think of a human desire to be free and have autonomy over their destiny. Patients should be adequately counseled and informed about the risk of OAT tapering, including the high risk of relapse and overdose. We should challenge the idea that successful recovery necessitates being off OAT. Ideal candidates for OAT tapers are those who have demonstrated clinical and psychosocial stability for at least 12 months. And it's important to have benchmarks that are not solely related to substance use when assessing stability. The other take-home point is recovery is an active process that's built over time through reaching goals in multiple domains of life and should be thought of as capital. OAT tapers are most likely to be successful when done over a long duration, so generally years with gradual dose reductions and stabilization periods in between. Extended release buprenorphine may be a novel method for OAT tapering that minimizes withdrawal symptoms, and more research is needed to guide our clinical practice on how to taper OAT in a safe manner that minimizes risk of destabilization and relapse. And these are just my final thoughts. So I think when we might view patient-requested taper OAT as, the patient not understanding the benefit of OAT or underestimating the dangers of relapse, I think we should also see it in, as a positive light, it's a reflection of the hopes that they have for themselves in the future. And so while OAT tapering is not something, we should encourage or recommend from a medical standpoint, I think there's something to be said about the importance of encouraging optimism and having dreams for the future in the recovery process. And so that brings me to the end of my presentation. Thanks for your time.
Okay, thanks, Alex. That was a really wonderful overview of the data, and I appreciated kind of your reflections as a provider and a primary care provider specifically. Any questions from the audience? I'll start perhaps while everyone's gathering their thoughts. I'm curious how, if you can talk to us a little bit about like just practically speaking, how you navigate this conversation with people when they bring it up, and specifically, how might it differ if you're seeing somebody who's asking about this, 6 weeks or 8 weeks into treatment versus who has been on it for a year or two, and any advice from a practical standpoint on how to hold that conversation?
Yeah, I think really the key piece is asking patients why they want to discontinue OAT. And I think that reason will be individual and personal for every patient, but I think it's definitely challenging. Like, we will sometimes have patients that request like a more rapid kind of detoxification approach. Like, they'll be on OAT for a few weeks and want to come off. So I think in these cases, again, just providing information so that they can, ultimately it is their decision. We can't force them to take a medication, but providing them with the information so that they can make an informed decision. And I think letting them know your concern as a provider is why something you would not recommend, the risk of fatal overdose, of mortality and morbidity is something that they should be adequately counseled on. And then I think, offering them options as well. Like, if it is like, the witness dosing, that's a problem, like try, offer them a switch to Suboxone or Sublocade to give them a more flexibility in their day-to-day life. But I think, it's different if you're talking about a patient that's, that you see in your primary care practice that you've been following for years, that, has not, used unregulated supply for a while. That might be, a more appropriate case where you might consider an OAT taper or going down on the dose. But I would generally try to, encourage people to stick on it if they've only been on it for, less than 12 months.
Cool.
Yeah, I just had a question. I'm sorry, I came in late, so you may have touched on it earlier in the presentation, but did you see anything in regards to like age of the patient around how best to taper? Because I know, like, in my practice, I've noticed like young people tend to want to taper a lot quicker than maybe necessarily like older people, and so I was wondering if there was any evidence for that being an option for younger people as opposed to those who maybe have a longer opioid use disorder.
Yeah, I think that's a good question. And something that, that we see in clinical practice too, that often youth, want to come off more quickly. And I think maybe that's related to that study where they talked about the youth perception that they view their substance use disorder as more kind of like, a transient behavior rather than like a lifelong illness. And, maybe being younger as well, they tolerate the withdrawal symptoms better, or they've had, they've had a less duration of their opioid use disorder. So, they might benefit, they might be able to tolerate a faster withdrawal, but there's not a lot of research that I found that spoke to, differing tapering approaches based on age and using age as a, predictive or prognostic factor for this.
Julius?
Thanks, Alex, for your presentation. It's really great. I really like the you touched on recovery capital. I'm wondering, do you use the recovery capital in your conversations about tapers itself? And then in what way would you use it?
Yeah, that's a good question. It's not something that I've used yet. It's something that I came across when doing this presentation, but I thought that was really insightful and one that I want to incorporate. And I think it's the idea that thinking about capital, recovery as capital, like it's an asset that can be, built up over time and accumulated. It's a resource that you can use to support, your recovery from addiction. The way that I would use it is kind of talking about it with patients like that. We know, recovery is not just, an end stage that you reach, but it's an ongoing process and consisting of multiple things, not just medications. And I'm thinking about recovery in terms of multiple domains of life. So the clinical and physical health, stability is important, but those other areas too that I think sometimes we overlook, like, social connection or spirituality or having a sense of purpose and meaning. And I think those are all things that we should try to think about when patients come to us about OAT tapers. Okay.
How long would you go in between decreasing the dose? Like, would it be like a month? Would it be longer? Or would it go on by person?
Yeah, that's a good question. Probably do like, check in probably at least, bi-weekly or monthly, or it could even just be, a phone check-in. Maybe you'll do like a dose reduction like half of the time. So I think the article that I looked at, the ones that were most successful had only had dose reductions in 25 to 50% of the visits, and then the rest of the visits were just used to like do check-ins, assess their stability, and yeah, not going down on their dose every visit. And really be very individualized. Like I would check in every time, like if they say like, you know, they're like they have a lot of ongoing stressors, they have a lot of triggers for their use, they're reporting increased cravings, and I would just hold the dose for as long as, you know, the patient feels ready to continue tapering. It's not something like benzodiazepine tapers where I try to encourage patients to be consistent about dose reductions, like going down even by like a small amount every visit. I think is important in those cases where the goal is, yeah, we want to try to get them off benzodiazepines. But for OAT tapering, like we really, you know, if they want to stay, if they need to be on it for longer, it's not something that we're in a rush to try to get them off of. So.
Part of the question is, how much would you decrease the by?
Yeah, it's probably, that's a good question. Like there wasn't a lot of evidence to guide this or give specific recommendations, but like I personally wouldn't go probably more than like 10 milligrams at higher doses. I would definitely slow it down once they like, you know, once they get to lower doses, like, you know, maybe at 100 milligrams, maybe going down by 5, again, very individualized. I would check in with the patients. Like in my experience, I've seen some patients like, you know, report like, you know, severe withdrawal symptoms, like just going down by like, you know, 2.5, or even at the lower doses, like going down by just like 1 milligram, like, you know, they feel withdrawal symptoms. So I think, yeah, just being careful at those lower doses too, because that those withdrawal symptoms can definitely be a trigger for relapse and high risk use.
If I can just add to that, because I think that's really wise. But the other part about checking in people and being flexible, I think that giving people agency and some participation in it, the control that gives somebody, and being able to kind of help adjust their tapering schedule helps for some people. These alleviate a lot of that anxiety that may be leading up to a potential drop. Just knowing that this is a collaborative decision-making process.
Yeah, I think that's a really good point, because I think some of the themes that emerged in the qualitative research was that, you know, patients often feel like a lack of control, like being on their medication. So I think, you know, this offering them some agency and like control over, you know, the tapering process might give them some of this sense of control back.
By that, to clarify, you mean by giving like additional like PRNs for them to take home, or just in terms of like the actual decision?
I mean, I mean more like decision making around if they want the dose to decrease. So I would kind of let them be in the driver's seat. Like if they think that, you know, they want to hold the dose, you know, for a while because they have, you know, ongoing life stresses, and, you know, I definitely want to support them in that decision.
Question: do you know that for the like off-script Sublocade trials that are ongoing, is it really looking at like Suboxone 2 milligram, giving them like a Sublocade 100 and seeing how that turns out, or are they looking at also like 4 milligram, or kind of going back up to 8 milligram and then giving, or even like partial injection of Sublocade?
Yeah, that's a really good question. To my knowledge, I don't think there's a clinical trial about this being done currently that I found. But yeah, you make a good point. Like, you know, the patients in this were on low dose Suboxone, so at doses of like 2 to 4 milligrams. So maybe the one-time dose of 100 milligrams of Sublocade was sufficient in this case. And again, they were patients that had prescription OUD, so they weren't patients that were using fentanyl. In other patients, you know, they might require, you know, higher dose Sublocade for a longer period of time in order, you know, to provide that stabilization so that they, you know, can auto taper without severe withdrawal symptoms.
I don't know. I'm not aware of any clinical trials around something. The individual is definitely aware of that. That was just a case study of I think 4 cases in that case report. But there's another product out there called Brixadi, which is not available in Canada yet, but maybe coming in the near future, which is another injectable extended release formulation view. But it comes in more doses and in week-long and month-long intervals. So there's a lot more theoretically flexibility built into it that I think that there's some ongoing work looking at how it can be used for withdrawal management. Any other questions? So I think that this this is a really practical and important topic for those of you who are just sort of taking this in. This recording will be available on the CCSC website if you ever need to go back for a refresher. But otherwise, I really appreciate you coming and sharing this with us, Alex, today. that was a very thorough review of an area that has very little literature to it. And so I really appreciate you giving us that update. And we will see everyone back here in September for the first from our new cohort of fellows.